Now let's see organophosphate poisoning. In organophosphate poisoning, there is increased secretions like diarrhea, excessive salivation, excessive sweating, and urination. Also, there will be decreased heart rate, decreased blood pressure, pinpoint pupil, and the drug of choice for OPC poisoning is atropine. Very important. In organophosphate poisoning, you will be given history of a farmer. Very important. Now let's see this question. A young boy was brought to the hospital with complaints of few episodes of fast blinking and staring at something for around 20 seconds. On electroencephalography shows spike and wave pattern. This spike and wave pattern is characteristic for petit mal epilepsy. Petit mal epilepsy is also known as absence seizures. Now the question is asking which of the following drugs should be used for the treatment. Now this is a young guy. In absent seizures, we give sodium valproate. If ethosuximide is in the options, we will choose ethosuximide over the sodium valproate. Most teratogenic anti-epileptic drug is valproate, very important. And least teratogenic anti-epileptic drug is levetiracetam and lamotrigine. L for least. Now let's see some drug of choices for the seizure disorders. In tonic seizures, the drug of choice is valproate. The highlighted yellow colors are very important. You need to remember them. For absence seizures in children, drug of choice is ethosuximide. Absence seizures in adults, drug of choice is valproate. For GTCS, drug of choice is valproate. For myoclonic seizures, drug of choice is valproate. For infantile spasm with tuberous sclerosis, the drug of choice is vigabatrin. For infantile spasm, ACTH, status epilepticus, lorazepam, IV lorazepam. Seizures in pregnancy, magnesium sulfate, very important. Then neonatal convulsions, phenobarbital. These are the important drug of choices you need to remember. Now, anti-tubercular drugs. There are first line anti-tubercular drugs and second line anti-tubercular drugs. In first line anti-tubercular drugs, you need to remember HRZES. H for isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol, S for streptomycin. These are the first line drugs. Isoniazid, rifampicin, pyrazinamide, and streptomycin, they are cidal drugs. They kill the bacteria. But ethambutol is static drug. It decreases the growth of a bacterium. Okay. Now, in second line drugs, we have fluoroquinolones, oral drugs, and injectable drugs. Among fluoroquinolones, we have ofloxacin, levofloxacin, and moxifloxacin. In oral drugs, we have drugs like ethionamide, prothionamide, cycloserine, rifabutin, para-aminosalicylic acid, rifapentin, terizidone. In injectable drugs, we have kanamycin, amikacin, and capromycin. Very important. Now let's see drug resistant tuberculosis. There is monodrug resistant tuberculosis, polydrug resistance, MDR multi-drug resistance, rifampicin resistance, XDR extensive drug resistance, and total drug resistance. In monodrug resistance, when resistance to one first line anti-tubercular drug. Polydrug resistance means when there is resistance to more than one first line anti-tubercular drug except isoniazid, and rifampicin. In multi-drug resistance (MDR-TB), there is resistance to isoniazid and rifampicin, but with or without resistance to other first-line drugs. Important is to remember that multi-drug resistance is resistance to isoniazid and rifampicin. Rifampicin resistance means resistance to rifampicin. Then extensive drug resistance, that is XDR-TB. It is very important, already asked in your exam. It is resistance to isoniazid, rifampicin, any fluoroquinolone like ofloxacin, levofloxacin, moxifloxacin, plus any second line injectable like amikacin, capreomycin, and kanamycin. Very important. Total drug resistance means resistance to all available drugs for TB. Now let's see another important topic, that is trichomoniasis. Trichomoniasis is caused by Trichomonas vaginalis. Now remember some important features about Trichomonas vaginalis, which is very important. It is 3 to 10 flagella containing. It is motile because it contains flagella. It does not have any cystic stage. It does not have cystic stage. It gives greenish white discharge. In trichomoniasis, you will see colpites macularis, which is also known as strawberry cervix or strawberry vagina. As you can appreciate in this image here, this is the cervix here, and as you can see here, some dots here. This is a case of strawberry cervix. Sorry. Now, the drug of choice is metronidazole for both partners because it is a sexually transmitted disease. And this is the trophozoite of Trichomonas vaginalis, as you can appreciate here. This is the Trichomonas vaginalis, very important. Now see this question. A female patient presented with greenish vaginal discharge, and clue cells were present. Very important. Clue cells were present and whiff test is positive. There are a lot of hints in this question. What is the drug of choice? This is the case of bacterial vaginosis. In bacterial vaginosis, there will be clue cells, whiff test is positive, greenish vaginal discharge will be there, and this bacterial vaginosis is caused by Gardnerella vaginalis. Gardnerella vaginalis. Now, what are clue cells actually? In clue cells, as you can appreciate here, this is the vaginal epithelial cell. Now, see in this image, over the vaginal epithelial cell, there are a lot of bacteria, lot of Gardnerella vaginalis. When vaginal epithelial cell is covered by lot of Gardnerella vaginalis, that is known as clue cell. Okay. In bacterial vaginosis, the drug of choice is metronidazole. Now let's see another important question. A female patient was treated with clindamycin. Clindamycin is the antibiotic and developed diarrhea. See here, a patient is given antibiotic. Now she has developed diarrhea. It is most probably pseudomembranous colitis. Pseudomembranous. The diagnosis is given here. Which of the following is most likely organism? This pseudomembranous colitis is caused by Clostridium difficile. Clostridium difficile. Now remember this Clostridium perfringens, which is also known as Clostridium welshi. It causes gas gangrene. Very important. It causes gas gangrene. In the gas gangrene MCQ, you will be given the history of an injury to a patient, And due to injury, in question you will be given crepitus. This is the main clue in the question, crepitus. What does it mean, crepitus? Crepitus means gas in the tissues. That will be the key point for your diagnosis. And in the gas gangrene, there will be foul smelling discharge. Three important points: injury, crepitus, and foul smelling discharge. Even there will be severe pain in the gas gangrene. Remember, in the pseudomembranous colitis, the drug of choice is fidaxomicin. Oral vancomycin was the drug of choice in pseudomembranous colitis, but nowadays the drug of choice is fidaxomicin. Clostridium tetani causes tetanus. Now remember these important points. Substance is increasing absorption of iron or hydrochloric acid and vitamin C, that is ascorbic acid. Substances decrease absorption of iron like phytates, oxalates and tannates. A patient was given halothane for general anesthesia. He developed rigidity and hyperthermia. These symptoms are most likely due to which ion? See guys, this is the case of malignant hyperthermia. In malignant hyperthermia, you will be given the history of halothane given for the general anesthesia, and the patient will be having rigidity and hyperthermia. Malignant hyperthermia itself is characterized by rigidity and hyperthermia. Why it occurs? It occurs due to overactivity or mutation of ryanodine receptors. Ryanodine receptors. What these receptors are going to do? These ryanodine receptors helps in release of calcium ion. They help in release of calcium ion from sarcoplasmic reticulum. Once this excessive amount of calcium is released, it leads to severe contraction and results in rigidity and hyperthermia in a patient. So the question was asking, these symptoms are most likely due to which ion? The answer will be calcium. Hope this is clear to you. Now, see another very important question. A lady was stung by many bees. She developed breathing difficulty and hypotension. What is the drug of choice? See guys, this is a case of anaphylactic shock. In anaphylactic shock, it is actually a type of allergy in which there is severe bronchoconstriction with hypotension. In anaphylactic shock, you will be given two things: severe bronchoconstriction with hypotension. How you treat anaphylactic shock? The drug of choice is adrenaline. How much dose you give? First, you give it IM, intramuscular, and the dose is 1 is to 1000. The answer will be adrenaline. Now, let's see another important topic, that is cocaine toxicity. In cocaine toxicity, what you are going to see, the important thing you need to remember is there will be sympathetic symptoms. In cocaine toxicity, there will be sympathetic symptoms because cocaine itself is a sympathetic substance. There will be hypertension, tachycardia, mydriasis. And in the toxicity of cocaine, there will be tactile hallucination, and the patient will feel like that insects are crawling on his skin. Tactile hallucinations are also known as Magnan's phenomenon, also known as cocaine bugs, like insects are crawling on the skin of a patient. Due to these tactile hallucinations, patient will be itching and there will be scratch marks on the skin. Okay. Now let's talk about atropine poisoning. Atropine poisoning. This atropine is present in a datura plant. Is present in the datura plant. Very important. Atropine is an anticholinergic substance. Therefore, the patient will be having anticholinergic symptoms like dry skin, increased body temperature, increased heart rate mid races. See, guys, to crack this question, you will be given the history of a child eaten an unknown plant and presented in a comatose state in emergency. These will be the points, hints in the question. So be cautious about these points. Now let's see another important topic. A patient of muscle weakness. If a patient is having muscle weakness, we do a test known as Adrophonium test. Adrophonium test is also known as tensilon test or ameliorative test. See, Adrophonium is a drug which is acetylcholine esterase inhibitor. Okay, when we give this drug to this patient who is having muscle weakness, if muscle weakness improves, this is the case of myasthenia gravis. If this muscle weakness worsens after giving Adrophonium, then this is the case of cholinergic crisis. Very important. Now let's see these cylinders. Oxygen cylinder. This is the oxygen cylinder. Black and white. Black and white. Antonox. Antonox is blue body, white shoulder. Blue body, white shoulder. Antonox contains nitrous oxide plus oxygen. And blue cylinder contains only nitrous oxide. N for Neela. Helium is a brown cylinder. Okay, in brown cylinder we have helium. Now let's see bronchial asthma. In bronchial asthma, we know it's an allergic condition in which there is severe bronchoconstriction. For that, we are giving bronchodilators. In bronchodilators, we can give beta 2 agonists. Beta 2 agonists causes bronchodilation. Among beta 2 agonists, we have salbutamol, salmeterol, formoterol, these drugs. The drugs ending with metro or long acting. Okay, we have parasympathetic drugs which are M3 blockers. They are also going to cause bronchodilation. That M3 blockers include ipratropium, tiotropium. Also, we have another group of drugs, that is phosphodiesterase inhibitors. They are also bronchodilators. What they are going to do, they increase camp levels. By increasing the camp levels, they can cause bronchodilation and vasodilation. Phosphodiesterase inhibitors include theophylline, aminophylline. Now, note, phosphodiesterase enzyme inhibitors are used in erectile dysfunction. Okay, they are used in erectile dysfunction. The drugs used in erectile dysfunction are sildenafil and tadalafil. These are the drugs which are used in erectile dysfunction, and they are phosphodiesterase enzyme inhibitors. Remember, sildenafil is phosphodiesterase enzyme 5 inhibitor. How to remember? S looks like 5. Okay, tadalafil is long acting phosphodiesterase enzyme inhibitor. Very important. Now, This was the first class of drugs which are bronchodilators used in the bronchial asthma. Now another class of drugs is steroids. In asthma there is inflammation also. To reduce that inflammation we can use steroids. Steroids are strong anti-inflammatory drugs. They are strong anti-inflammatory drugs. Among steroids we can use beclomethasone, budesonide, etc., etc. Okay. In there is another class of drug, that is mast cell stabilizers. Mast cell stabilizers. We know the mast cells release histamine, and uh, histamine causes bronchoconstriction. To prevent that, we can give mast cell stabilizers like sodium chromoglycate, ketotifen. Ketotifen. Now we have another class of drugs, that is monoclonal antibody against IgE. See, this IgE, E causes allergy, E for allergy. So this is the antibody which causes allergy. So we can give the monoclonal antibody against the IgE, which is known as omalizumab. Omalizumab. Now let's see this question now. Which of the following drug used in emergency management of asthma does not act by causing bronchodilation? Does not act by causing bronchodilation. See, in emergency management of asthma we can use all drugs: salbutamol, ipratropium, darifilin, hydrocortisone. All these drugs can be used. But the question is asking which does not act by bronchodilation. I have told you salbutamol, beta 2, as you can see here, it is beta 2 agonist. Ipratropium, as you can see here, they are M3 blockers. They cause bronchodilation. Darifilin, theophylline like drugs, they are phosphodiesterase enzyme inhibitors. All these are bronchodilators and can be used in emergency management of asthma. But hydrocortisone is strong anti-inflammatory drug, that is steroid. It is used in the emergency management of asthma, but it is not a bronchodilator. Now let's see dopamine doses. We have low dose of dopamine, intermediate dose of dopamine, and high dose of dopamine. Low dose is less than 1 to 2 microgram per kg per minute. Intermediate dose is 2 to 10 microgram per kg per minute. High dose is greater than 10 microgram per kg per minute. On low dose, D1 receptor is stimulated. This D1 receptor is present in renal blood vessels. This D1 receptor is present in renal blood vessels. Once this D1 receptor is stimulated at low doses, it is going to cause renal vasodilation. Once the renal vasodilation has occurred, it increases the renal blood flow. Now, at intermediate dose, D1 is also stimulated, but beta 1 is also stimulated. D1, beta 1, and once the beta 1 is stimulated, it means it is a positive chronotropic effect. There will be tachycardia. On high doses, alpha 1 is also stimulated. At alpha 1, vasoconstriction occurs, because when the alpha 1 is stimulated, there will be vasoconstriction, and finally there will be increased blood pressure. So remember D1, beta 1, alpha 1. D1, beta 1, alpha 1. I hope this is clear.